I'm Dr. Purnashri and welcome to second part of question paper discussion of Orthodontics and Dentofacial Orthopedics. So today we'll be discussing the topics functional development, occlusion, the basic concepts, classification of malocclusion and etiology of malocclusion. So let's start with the first topic, functional development. So in this topic we have short essay questions. The first one is, what are trajectories of force? List out and explain the different trajectories for maxilla and mandible. So coming to the first part of the question, what are trajectories of force? These are the lines of orientation of bony trabeculae that correspond to pathway of maximal pressure and tension. That means the trabeculae are thicker in regions where the stress is greater. More the stress, thicker the lines. And so they will orient along the pathway of maximal pressure and tension. So coming to second part of the question, what are the different trajectories for maxilla and mandible? First we'll discuss for maxilla. The trajectories of maxilla are horizontal and vertical. The horizontal trajectories are hard palate, orbital ridge, zygomatic arch, palatal bones and lesser wing of sphenoid. So you can add a diagram also here, and the vertical trajectories are frontonasal buttress. So these will arise from the incisors canine and the first premolar. Then they pass cranially along the pyriform aperture through the nasal bone and then terminate in the frontal bone. Then the second one is malar zygomatic buttress. So these stress lines arise from the buccal teeth. There are three pathways here: through the zygomatic arch, then through the frontal bone and lateral to the orbit, and then the third is along the orbital margin to join the frontonasal buttress, and the third is the pterygoid buttress. The pterygoid buttress transmits forces from the second and third molar to the base of the skull. The trajectories in the mandible. So here the line of stresses extend from one condyle, pass through the symphysis and end in the other condyle. Then there are a number of vertical trajectories below the mandibular teeth. So the mylohyoid ridge, that is here, and the lower border of the mandible are the prominent buttresses. So this finishes our first question. The second question is, describe the features, pathophysiology and treatment of infantile swallow. So infantile swallow is the swallow that is seen in infants. It is an autonomic reflex in human beings, and it is common to see this till 1.5 to 2 years. That is till the deciduous teeth erupt. The features of this are, the jaws are apart and the tongue is between the gum pads during the swallow. Then the second feature is, the mandible is stabilized by contraction of the perioral muscles. So these perioral muscles are basically the facial muscles that are innervated by the 7th cranial nerve. And the tongue tip is protruded forward between the gum pads. And then one more feature that can be seen is, if this infantile swallow is retained over more than 2 years of age, then speech disorders can be seen. Coming to the pathophysiology of retained infantile swallow, so we'll discuss the different causes that are possible. First is retained infantile swallow. Here, usually when at 6 months of age, when the incisors erupt, the tongue goes back and the retained infantile swallow stops. But however, if the tongue continues to thrust forward, we call it a retained infantile swallow. The second reason could be an upper respiratory tract infection. So when there is an upper respiratory tract infection like tonsillitis, allergy, because it is painful, the tongue is moved forward, and so the tongue thrusting can be seen. Another reason could be a neurological disturbance such as hyposensitive palate or moderate motor disability, disruption of sensory control and coordination of swallowing. This can also lead to a tongue thrust. Other reason is functional adaptability to transient change in anatomy. That is, the tongue can protrude when the incisors are missing. And then the feeding practices. If bottle feeding is more than the breastfeeding, then also this type of infantile swallow can persist. Then some certain oral habits, it could be hereditary, or if the tongue size is abnormal, even then we can see this retained infantile swallow. Coming to the treatment of infantile swallow, the first method is to correct the swallow and the posture of the tongue. So how do we do this? There are certain exercises that we call the myofunctional exercises. So this is to train the tongue to correct the swallow pattern. This can be exercises such as 1 elastic swallow, tongue hold exercise, 2 elastic swallow, etc. And then we can also advise some speech therapy. Another method to treat this is giving a Nance palatal arch appliance and teaching the patient the correct pattern of swallowing. Or we could even use an oral screen or a removable or a fixed habit breaking appliance such as a tongue crib. And then in an adult patient, surgical treatment can also be done. Coming to the short notes in this topic, pericision. So pericision is also called as circumferential supracrestal fibrotomy. So this is an adjunctive procedure. Adjunctive means additional procedure to prevent relapse following orthodontic treatment, particularly in rotations. So the supracrestal fibers are the main fibers responsible for the relapse. In pericision, we surgically transect these supracrestal fibers, and thus this helps in prevention of relapse. The second question, gum pads. So gum pads are alveolar processes at the time of birth. These are pink in color, firm and covered by a dense layer of fibrous periosteum. The upper gum pads are horseshoe shaped and the lowers are U-shaped. And then the parts of the gum pads will be gingival groove, dental groove and the lateral sulcus. And the normal features during this gum pad stage is there you will see an anterior open bite, there will be a complete overjet and a class 2 pattern between the jaws. All these three will get corrected by themselves at a later age. The next question is Wolff's law. So Wolff's law was given by a German anatomist and surgeon named Julius Wolff in the year 1870. So what does this Wolff's law state? If there is any change in direction or magnitude of force, this will produce a change in the internal architecture, that is the trabecular pattern of the bone, and the external form, that is the shape of the bone. So this is also called as the Wolff's law of transformation of bone. So what does this mean? What does all this means is, if there is increase in function, it increases the density of the bone. The next question is Wolff's law of trajectories of forces. So the trajectories of forces law was given by George Hermann von Meyer. So this states that the trabecular lines, they are oriented in such a way that they follow the pathways of maximal pressure and tension. This means that the trabeculae are thicker in the areas of maximal stress. And in usually most of the bones, these trabecular cross each other at right angles. So this type of arrangement helps to resist the stresses on the bone. This is what is the law of trajectories of force, and the Wolff's law is based on this. Coming to our next topic, occlusion, the basic concepts. Here also we have some short essays. The first question is enumerate 6 keys to normal occlusion and explain interarch molar relation in detail. So who gave the 6 keys to normal occlusion? This was given by Lawrence F. Andrews in 1972. So he said these 6 characteristics are important for a normal occlusion. These characteristics are, first one is molar interarch relation, mesiodistal crown angulation, labiolingual crown inclination, absence of rotation, tight contacts and a curve of spine. These are the 6 that were given by Andrews. However, a seventh one is added by McLaughlin and Bennett. It is to correct tooth size, that is correct Bolton's proportion. The second part of the question is explain interarch molar relation in detail. That is the first key to the normal occlusion. So according to Andrews' occlusal concept, the mesiobuccal cusp of the first molar should occlude in the groove of the mesial and medial buccal cusp of the lower first molar. This you must be knowing very well by now. This is the normal class 1 relation that we know. But Andrews' occlusal concept, there are few more points to this. That is, the mesiolingual cusp of the upper first molar should occlude in the central fossa of the lower molar. The crown of the upper molar must be angulated so that the distal marginal ridge occludes with the mesial marginal ridge of the second molar. Then coming to the premolars, these three were about the molar, first molar. The premolars should have a cusp embrasure relation buccally, and lingually they should have a cusp to fossa relationship. Then we finished molar, premolar, the canines. The maxillary canine should have a cusp embrasure relationship with the mandibular canine and first premolar, and the cusp tip is slightly mesial to the embrasure. Then the maxillary incisors must overlap mandibular incisors and the midlines of the arches should match. So the Andrews class 1 occlusion, there are these points. So the first three are about the molar, buccally, lingually, and the marginal ridge, how it should be. Then we talk about the premolar, buccally and lingually, then about the canine, and then the incisors. So you can put this diagram as well. You can show the buccal, mesiobuccal cusp of the molar, the marginal ridge relation, the angulation such that the distal marginal ridge is relation, the premolar relation also. Then the next question is, what are the 6 keys of occlusion? So in this particular topic, 6 keys of occlusion, you must know these 6 points, and then add a note on curve of Spee. These 6 we already discussed. Then coming to the curve of Spee, you have to draw this diagram to show what is the curve of Spee. So curve of Spee is normal occlusal plane according to Andrews. It should be flat. The curve of Spee should be flat. The mandibular curve of Spee should not be deeper than 1.5 mm. So why does this curve of Spee deepen? As the lower jaw grows downwards and forwards, it's sometimes faster and continues longer than that of the upper jaw. Since the lower jaw is growing more than the upper jaw, the anterior teeth can be forced backwards, and then there can be anterior crowding of the teeth. So therefore, when the anterior teeth are tipped backwards, the curve of Spee deepens. Then another reason could be at the molar end. As the third molars are erupting, they push the molars forward. So this also causes a deepening of the curve of Spee. And the treatment of this is to flatten the curve of Spee or even overcorrect it, reverse the curve of Spee so that after relapse it maintains as flat curve of Spee. Next, let's discuss the short notes in this topic. First question is Dewey's modification of angles classification. So Dewey has subclassified angles classification, the angles class 1 and class 3. There are no Dewey's modification for class 2. For class 1, he is divided into 5 types. Dewey classified into 3 types, and later Anderson has added 2 more types. So the type 1 is class 1 molar relation with crowded anterior teeth. Type 2 is class 1 with protrusive maxillary incisors. Type 3 is class 1 molar relation with anterior crossbite. Type 4 is class 1 molar relation with posterior crossbite. And type 5 is drifting of permanent first molar due to extraction of deciduous second molar. There are no modifications for class 2 given by Dewey. And class 3 he has divided into 3 types. Type 1 is class 3 molar relation with normal incisal overlapping. That means there is no anterior crossbite. Type 2, there is edge to edge incisor relationship, and in type 3 the incisors are in crossbite relation. The second question is leeway space. So leeway space was described by Nance. So it's also called as leeway space of Nance. It was described in 1947. So this space is basically the combined width of mesiodistal width of the deciduous molars and the canine. You can see in this diagram here is usually greater than that of the permanent premolars and the canine width, mesiodistal width of the premolars and the canine. So whatever is the difference between these two widths is called as the leeway space of Nance. So this is around 0.9 mm per segment in maxilla. So both the arches together it is 1.8 mm, and in the mandible it is 1.7 mm per arch per segment. So it comes up to 3.4 mm in the mandibular arch. So this space is utilized to correct the flush terminal plane to a class 1 molar relationship. So next question is, what is a flush terminal plane? Flush terminal plane means the mesiodistal relation between the distal surfaces of the upper and lower second deciduous molars is called the terminal plane. So when these two are flat, are in a same vertical plane, we call it a flush terminal plane. And this is a normal feature seen in the deciduous dentition. And it gets corrected later on as the permanent teeth erupt. The other questions are Andrews 6 keys of occlusion, which we have discussed already, and curve of speed. This also we have discussed in the short essays. What is canine guided occlusion? So this you must have learnt or come across in Prosthodontics as well. So in canine guided occlusion, what it means is during lateral movement, that is side to side movement, the opposing upper and the lower canines, they come in contact in the working side, that is the side to which the jaw is moved. Okay, and then this causes disocclusion of the posterior teeth on the working and balancing sides, both the sides. The posteriors are disoccluded and the contact is only near the canines. So this is called as the canine guided occlusion, and this is seen usually in young individuals where the dentition is not worn, unworn dentition. With that we finish that topic, and now we move on to classification of malocclusion. The first question is, enumerate the various classifications of malocclusion. Explain angle system of classification of malocclusion. Mention the advantage and disadvantage of angle system of malocclusion. So there are three parts to this question. First is to list out the classifications of malocclusion. Second part is to explain the angle system. Third is advantages and disadvantage of angles classification. So the systems of classification are angles classification, Andrews 6 keys of occlusion, skeletal classification, British standard classification of incisor relation, canine classification, Simon's classification, and Ackermann and Prophet classification. So these are the different classification systems that are normally used. Next we'll explain the angles system of classification. So this was given by Edward H. Angle in 1899, and this was the first classification that was given for a malocclusion. So this is the most commonly used classification, and you all must be very familiar with it. So this is based on the relation of the mesiobuccal cusp of the maxillary molar and the buccal groove of the mandibular molar. So this relation, it is divided into class 1, 2, 3, and there are modifications given by Leicester and Dewey. You can just draw in this flow chart. Angles classification, class 1 malocclusion, class 2 the division, subdivision, class 3 malocclusion, class 3 true class 3 and pseudo class 3, and the subdivision. So coming to the advantages and disadvantages of this system of classification. Angle system is easy and it is a practical method. It is rapidly used. It can be done quickly. Then there is no need of any special instruments, and it is easy to communicate between people, and it is widely used for teaching purposes. Then coming to the disadvantages, we have that it describes the malocclusion only in anterior posterior plane. So when I say class 1 malocclusion, you won't know if there is a deep bite or an open bite, or if there is a constriction, cross bite. It does not explain all of that. So it explains only in anterior posterior plane. And another drawback is that angle considered that the first permanent molar is a fixed point, but it was not found so. So the first permanent molar can also be defective. He did not take that into consideration. It cannot be used if the molars are extracted or missing. It cannot be used in a deciduous dentition. It does not differentiate between skeletal and dental malocclusions, and it does not explain the etiology or the cause of the malocclusion, and it does not explain the individual tooth malocclusions. So these are the disadvantages. Let's move on to the next question. Enumerate Andrew's 6 keys to normal occlusion and describe in detail angle system of classification. Add a note on its drawback. So this we have already discussed in the previous 2 questions, and we have this is the combined question of those questions. Moving on to the short essays. The first question is classify class 3 malocclusion and explain in detail the management of skeletal class 3 malocclusions. So the class 3 malocclusion according to angle is divided into true class 3, pseudo class 3 and a class 3 subdivision. So a class 3 malocclusion is, we call it class 3 malocclusion when the mesiobuccal cusp of the maxillary first molar, it occludes with interdental space between mandibular first and the second molar. So the lower molar is more mesial than the upper first molar. Pseudo class 3 malocclusion, it is caused due to occlusal prematurity. That means there is some occlusal disturbance which causes the mandible to move forward from rest position to occlusion. So the mandible slides forward into a class 3 position. So it is also called as a postural class 3. And the third type is class 3 subdivision. It is a condition in which one side we have a class 3 molar and the other side is a class 1 molar relationship. Coming to the treatment of class 3, there is interception during growth, treatment with fixed appliance, treatment of anterior crossbite, treatment of the posterior crossbite using expansion. Then there is role of extraction. So for class 3 malocclusion, usually the pattern can be upper second premolar and the lower first premolar extraction, or lower first premolar extractions only. And then there's treatment of severe class 3 after growth. This includes surgeries, etc., or we can do a camouflage using extractions again. And then there is treatment of pseudo class 3. So in pseudo class 3 we will remove the prematurity so that the mandible does not slide forward. The next question is describe the features of class 2 division 1 malocclusion and compare with that of class 2 division 2 malocclusion. So basically you have to compare division 1 and division 2 malocclusion here. So class 2 division 1, it's a condition where the class 2 molar relation is present with a proclined upper central incisors and there is an increased overjet. So there are two main points, the proclination and the increased overjet. Then you can write this answer in form of a table where, because they've asked to compare, you can draw this diagram also. The main difference is between class 2 division 1 and division 2 is that the upper central incisors are proclined in division 1 and they are retroclined in division 2. There is excess overjet and deep bite in division 1 and there is not much overjet in division 2, but there is a deep overbite. the arches are V-shaped or narrow in the canine region and broad in the molar region in class 2 division 1, whereas in division 2 they are broad, or usually we call it a square shaped arch. In class 2 division 1, the upper lip is short and the lips cannot be closed easily. In division 2, the upper lip is normal, but we will notice a deep mentolabial sulcus. In division 1 again, the mandible is usually short, whereas in division 2, it is usually, most commonly it is of a good size. So this is the comparison. Moving to the next question. List the various modifications of angles classification. This we have already discussed in the previous question on angles classification. And add a note on Simon's classification. So let's discuss Simon's classification. This was given by Simon in 1926. The dental arches are related to the planes. 3 different planes were given by Simon and the arches are classified based on that. The planes are Frankfurt's horizontal plane, you can see here, the orbital plane and the mid-sagittal plane. So when we check the teeth in relation to the Frankfurt's horizontal plane, we check for the deviations in vertical plane this way. So if it is the teeth are closer to the Frankfurt's plane, we call it attraction, and if they are away from the plane, we call it abstraction. Same way, in relation to the orbital plane, we check for deviations in the transverse plane in this direction, like this. So if they are closer to the orbital plane, we call it retraction, and if they are away, we call it protraction. Same way, for the mid-sagittal plane, we check for deviations in the sagittal plane. You can see this direction, right, in this way. So if they are closer to the plane, it's called contraction, and if it is away, it is called distraction. So mainly in this classification, you have to remember these terms: attraction, abstraction, protraction, retraction, contraction, distraction. And then these diagrams you can easily remember because those are the 3 planes. True and pseudo class 3 malocclusion. So this I have already discussed. Class 3 malocclusion normally is when the mesiobuccal cusp of the upper first molar occludes mesial to the more mesial to the class 1 position. And in pseudo class 3 position malocclusion, what happens is there is a occlusal prematurity which causes the mandible to move forward, and then it closes in a class 3 position. So it's also called as a postural class 3. Coming to the short notes, Dewey's modification we have discussed. Angles classification, this also we have discussed. What is Boehm's classification? So Boehm's classification is used in deciduous dentition. So we have discussed this flush terminal plane. So terminal plane means the relation between the distal surface of the upper and lower second deciduous molar. You have to remember this. Angles classification relates the first permanent molars. Boehm's classification for deciduous teeth usually is for deciduous or mixed dentition is the second deciduous molars. So in flush terminal plane, the distal surface of the upper and lower second molars are in one vertical plane. In a mesial step terminal plane, the distal surface of lower second molar is more mesial. So that is why it is called the mesial step. In distal terminal plane, the distal surface of lower second molar is distal to that of the upper. The next topic is, and the last topic for today, is etiology of malocclusion. The long essay in this topic is classify the etiology of malocclusion, describe in detail the local causes of malocclusion. So there are various classifications for etiology of malocclusion. The most common are the Moyers and the Grabers. So this is the Moyers classification. He divides the etiology into hereditary, and then the developmental defects of unknown origin, the malocclusion caused due to trauma, that can be before birth, that is prenatal, or after birth, postnatal, or caused due to a physical agent. This is the Moyers classification. And then there is malocclusion caused due to habits, diseases, or malnutrition. Then we come to the Graeber's classification. So Graeber gives two types of etiology. He says it can be caused due to general factors or local factors. In this question, they've asked for local factors to explain in detail. So the general factors are again hereditary, congenital, environment. The environment can be prenatal, postnatal. Then the predisposing metabolic, climate and disease. So these can be endocrine imbalances, metabolic disturbance, infectious diseases, and then the dietary or nutritional problems. It can also be caused due to abnormal pressure habits, that is the habits and the functional aberrations. These can be sucking habits, biting, nail biting, lip biting habits, abnormal swallowing, tonsils, respiratory problems, speech defects, or psychogenetic and bruxism. Then there is malocclusion caused due to improper posture or trauma or accidents. These are the general factors. Then there are the local factors that has been asked in this question. These local factors mean that are inside the mouth. These are anomalies in numbers. So they can be extra teeth, that is supernumerary teeth, or few teeth can be missing. That will cause the malocclusion. They can be anomalies in size. If the teeth are too large for the jaw, then there will be crowding. If the teeth are small for the jaw, there will be spacing. And then there are anomalies in tooth shape. For example, the lateral incisors can be peg shaped. And then there are abnormal labial frenum. So mucosal barriers. If the labial frenum of the upper is thick, then that can cause the midline diastema. And then premature loss of deciduous teeth. This can cause crowding because of the mesialization of the permanent teeth. Prolonged retention of deciduous teeth. So if the deciduous teeth do not fall at the time of their proper shedding, this can cause improper position of the permanent teeth, that is erupting. And then there can be abnormal eruptive path, ankylosis. Then again, ankylosis of the deciduous teeth, there won't be space for the permanent tooth bud to erupt. So this will also cause certain malocclusions. And then dental caries. So caries can also cause loss of space and then the malocclusion. Moving to the next question. The short essay is enumerate the general and local factors in Graeber's classification. This we have already discussed just now. So with this we finish today's discussion topics. If you have any questions, doubts or suggestions, please leave it in the comment section. Thank you.